Patient assessment. The National EMS Education Standard Competencies for this particular chapter focuses on assessment. Assessment applies scene information and patient assessment findings, which includes scene size-up, primary and secondary assessment, patient history, and reassessment to guide emergency management. It will also include or focus on scene safety, scene management, the impact of the environment on patient care, addressing hazards, violence. The need for additional or specialized resources, standard precautions, how we approach dealing with multiple patient situations. One of the core competencies for this chapter will focus on primary assessment. Primary assessment for all patient situations. And the focus will be on the level of consciousness, assessing and managing ABCs, identifying live threats, assessment of vital functions, and what is meant by initial general impression. Based on assessment findings, we will focus on what is the most appropriate intervention to preserve life and how to integrate treatment and procedures required to preserve life. We will look at history taking, which is how we will gather information based on the chief complaint, the mechanism of injury, nature of illness, associated signs and symptoms. We will investigate the chief complaint, consider the patient's past medical history and pertinent negatives. In the secondary assessment, we will look at what is meant by a rapid full body scan and what is meant by a focus assessment, the difference between the vital signs and the primary assessment findings, techniques for physical examination for various systems within the body. We'll look at monitoring devices, obtaining and using information from patient monitoring devices, which include pulse oximetry, non-invasive blood pressure, entitled CO2 detector. And in the final competency, we will look at reassessment, how and when to reassess patients, how and when to perform a reassessment for all patient situations. Introduction. Patient assessment is very important. EMTs must master the patient assessment process. Patient assessment is used to some degree in every patient encounter. So it's a core skill that is basically applied to every patient that you encounter in the field, regardless of if this patient is a medical or trauma patient. There are 5 main parts of the patient assessment algorithm. And this includes the scene size of primary assessment, history taking, secondary assessment, and reassessment. As an EMT, you need to know the things that should be done and the things that should be considered in each of the main parts. So you need to know what should be done in a scene size up and what should be considered, and so on for the other main parts. The primary assessment is a very important part of the assessment algorithm, because this is where you initiate interaction with the patient, and this is where you will address things that can kill the patient fairly quickly. Rarely does one sign or symptom show the patient's status or underlying problem. As an EMT, you need to know the fundamental difference between a symptom and a sign. So symptoms are subjective conditions the patient feels and tells you about. So a symptom is based on what the patient tells you. Sign is based on your observation. So symptoms is what the patient complains of. Signs is based on your observation. So it's what you can see, what you can smell, what you can hear, and what can be measured. Now, starting with the first part of the patient assessment algorithm, the scene size up. Your evaluation of the condition in which you will be operating. You need to maintain situational awareness. The scene size up combines an understanding of the situation and conditions prior to responding. You will consider the information that you get from dispatch, and that will guide how you approach the scene, but you're not going to develop tunnel vision. And your actions will be based on your observations. Now, the first thing that we need to consider, or the first thing that needs to be done, is we need to ensure that the scene is safe. Issues can range from minor difficulties to major dangers. Do not enter until the scene is safe for you and your team members. Typically, the way you enter an area is the way you will leave. Wear high visibility safety vests on roadways, especially during times when vision can be affected, like at nights. Now, conditions that can affect terrain, traffic, and the environment should be considered. So you should consider how this will affect your ability to render care, to get access to the patient, how it's affecting you and your crew members. And if it's affecting you, it's going to affect the patient. So consider difficult terrain, consider traffic safety issues, consider environmental conditions. If appropriate, help protect bystanders from becoming patients. Hazards range from extreme weather conditions to the threat of physical violence. An emergency scene is a dynamically changing environment. Now, the main point of your scene safety is to look for anything that can be of danger to you, the crew, bystanders, and the patient. And if you think a particular resource is required to make that scene safe, then you need to request it before you start to put yourself at risk. That's the main point. If something is present on scene that is a danger to you and your crew, what are the resources that are necessary to make this scene safe? Request them. In the scene size up phase, we will determine the mechanism of injury or the nature of illness. The mechanism of injury is specific to trauma patients. The nature of illness is specific to medical patients. However, a patient can have a combination of both. Calls for assistance can be categorized as medical conditions, traumatic injuries, or a combination of both. The mechanism of injury is specific to trauma. And if we're thinking about trauma, we're thinking about forces being applied to the body And we have to think about the duration. How long was this force applied to the body? And we need to think about what area of the body the force was applied and what type of structures are underneath that area and what are the functions of these structures. How will the functions be affected? Now, when it comes to trauma, there are two main types of trauma. There are others, but there are two very common ones: blunt force trauma, penetrating trauma. With blunt force trauma, the force occurs over a broad area. The skin is usually not broken. Tissues and organs below the area of impact may be damaged, so the patient will have internal damage. With penetrating trauma, the force of the injury occurs at a small point of contact between the skin and the object. There is now an open wound with a high potential for infection, but in a pre-hospital setting, within a pre-hospital setting, the primary concern is going to be bleeding control. Then we consider risk for infection. Now, before I move to the nature of illness, what is important to note about the mechanism of injury is it is associated with trauma. And if we're thinking about trauma, we have to think about the forces involved, where they were applied, what type of body part was affected, what is underneath that area, and how that was affected. We also need to think about whether or not the force was localized or diffuse. So this force that was applied to the body, was it applied to a specific location, or the force was diffused throughout the body? If the force is localized, then your management will focus on the area that the force was localized to. If the force was diffused throughout the body, then you focus on the patient, the entire patient. The risk for spinal complications now exists. So you have to focus on the entire patient. So that's very important to note. With the nature of illness, for medical patients, determine the nature of illness. This is the reason why they contacted EMS. Why did they call? What is your chief complaint? Similarities between the MOI and NOI. Now, with the NOI, you can get this information directly from the patient. You can get it from family. You can get it from bystanders. Once the patient is able to give you information, then, and the information that you're getting is good information, then you will focus on the system involved. So if the patient is able to tell you what's happening to them, and they're able to do that very well, you focus on the system that is being affected based on your chief complaint. If the patient is not able to give you that information, then if you can get it from family members or bystanders, you will try to do so. However, if the information that you're getting from family members or bystanders is not appropriate, then you now have to focus on your ABCs and focus on the entire patient. And you need to include a few important vital signs. So you have to pay attention to the pupils. You have to pay attention to pulse oximetry, and you have to pay attention to the blood sugar levels. So use your senses to check for clue, what you can see, hear, smell, and what can be measured. Be aware of scenes with more than one patient with similar signs and symptoms. This can be a potential hazardous material situation. Example, carbon monoxide poisoning. It could indicate an unsafe scene for the EMT as well. Importance of MOI and NOI. Considering the MOI or NOI early can be of value in preparing to care for the patient. You may be tempted to categorize the patient immediately as either trauma or medical. Don't be in a hurry. If your assessment is thorough, so the less gaps you have in your assessment, the easier it will be for you to determine if your patient is a trauma patient, a medical patient, or a combination of both. Now, after we have ensured that the scene is safe and we consider the mechanism of injury and the nature of illness, we will also consider standard precautions or PPE, which is very important now more than ever. So wear personal protective equipment should be adapted to the pre-hospital task at hand. So you will gauge the task, and based on the task, you will use the most appropriate PPE. So for instance, if we are dealing with the airway and we're going to be doing procedures that can aerosolize mucus, then we want to cover our eyes, nose, and mouth. If we're dealing with a situation where there's a lot of body fluids or blood involved, then we want a gown, we want gloves and stuff like that. And if we suspect some type of respiratory tract infection, whether it's upper or lower, we approach these types of patients as if they have a communicable disease. So you probably want to ensure that you have on an N95 or a HEPA type mask when dealing with those patients. So the PPE is adapted to the task at hand. At minimum, always have on your gloves. Standard precautions have been recommended for use in dealing with objects, bloods, body fluids, other potential exposure risk of communicable disease. When you step out of the EMS vehicle, standard precautions must have been already taken or initiated. At minimum, gloves must be in place, consider glasses and a mask, or just use what you think is necessary based on the situation. Now, after we've taken the appropriate standard precautions for ourselves and our partners, we will consider the number of patients or determine the number of patients. During the scene size up, accurately identify the total number of patients. It is critical in determining the need for additional resources. When there are multiple patients, use the incident command system, identify the number of patients, and then begin triage. So we will determine how many patients we have on the scene. If it's more than one patient present, then we need to determine, do we have all the resources required to deal with these patients? If you don't, then you need to request those resources. And if you're the first unit to arrive on that location and there are multiple patients present that exceeds available resources, then triage must be initiated. And once we start to initiate a triage process, triage does not mean treating patients. It means to sort patients based on their priority until additional resources are available. There's a little delay on my slide. Come on. All right, there we go. So triage is a process of sorting patients based on the severity of each patient's condition. Again, triage does not mean to treat, it means to sort. Now, finally, we will consider the additional specialized resources. So when it comes to a scene size up, we need to ensure that the scene is safe. We need to consider the mechanism of injury or nature of illness. We need to take standard precautions. We need to determine how many patients we have. And if we have multiple patients, do they exceed our available resources? And finally, we need to consider additional or specialized resources. So some situations may require more ambulances or specialized resources. And this can include ALS transport if you're working in a first world system or a proper EMS system. Let me not say first world. Ear medical support, fire departments who may handle high angle rescue, hazardous materials, or water rescue, and of course, law enforcement. ALS is not available in Jamaica. Ear medical support, to some degree, I would think that the JDF can do that. And we have a fire department, we have a police force. To determine if you require additional resources, ask yourself these questions. Does the scene pose a threat to me, my patient, or others? How many patients are there? Do we have resources to respond to their conditions? And that would be our scene size up. So those are the things that we would do or consider in the scene size up. Now, the next part of the patient assessment process is the primary assessment. It can also be referred to as the primary survey, depending on the type of text that you're using. So the primary assessment, very important area in your assessment. This is where we make contact with the patient. This is where we will identify life threats and things that can kill a patient very quickly and occur very frequently in pre-hospital emergencies. Is the patient airway can be compromised. So if the airway is closed, they don't have a lot of time. The patient can have issues with their ability to ventilate. If they are having ventilation issues, then they can die very quickly from that. The patient can be bleeding excessively, and that causes shock. If that occurs, they can die very quickly. So in your primary assessment, your main goal, this is your main goal, and I don't think EMTs understand this concept very well, especially in Jamaica. It could be because there's a lack of protocols or a lack of sequential approach to assessing a patient. Your primary assessment is not where you obtain history for a patient, and that is a common practice. So there's a bad practice for EMTs to collect information on history in the primary assessment and neglect ABCs. It is where you manage life threats. So this is where you will identify and initiate treatment of immediate or potential life threats. And what is concerning to me is that the EMTs who decide to obtain a history in the primary assessment, they're not even obtaining a proper history. So they have made a decision to do a history in the primary and they're still not doing a proper history. That's very concerning. So your main goal in your primary assessment is to assess one brain, two lungs, one heart. That's your goal. You need to assess one brain, two lungs, one heart. If you have not done that, you have not covered your life threats. That is your goal in an emergency. So the physically examine the patient and assess LOC, airway, breathing, circulation. One brain, two lungs, one heart. Or you're assessing the nervous system, respiratory system, and cardiovascular system. Now, if you have been in EMS, if you have worked in the field and you have gained experience, what you need to understand is that the emergencies that you cover, whether it's medical or trauma, each patient will present differently. So each patient will present differently. So two patients can have spinal injury, but the presentation is different for both. However, a patient, when you encounter a patient in a pre-hospital setting, the patient will fall into 6 different categories of presentation. So there is 6 ways a patient can present to you in the field. Your goal as an EMT is to have a primary assessment approach for the 6 patient categories. The first 3 patient category presentation is a patient that will have adequate chest rise. So the first 3 ways in which a patient can present, that patient will have adequate chest rise. So you will be able to see visible chest rise in these patients. So the first one is a patient that can communicate with you. So when I have a patient in a pre-hospital setting, that patient can present in a way where they're alert, oriented, and they can tell me what's going on with them. They can tell me sensibly what's occurring. That's the first patient presentation. The second patient presentation is the patient is semi-responsive. So the patient is no longer able to tell me what's happening. However, he or she still has adequate chest rise. So their airway is not compromised to the point that ventilation is compromised. That's the second presentation. Patient can tell me what's happening, but they still have a adequate airway to provide adequate ventilations. The third category is the patient that is unresponsive. Again, this is a patient that won't be able to tell me clearly what's going on. However, if their airway is maintained, they will have adequate chest rise. So what does that mean? It means that if I have a patient that's unresponsive and their ventilation is not compromised, this is somebody I would probably consider keeping on their side and not let them lie completely flat if that is avoidable. So that's the first 3. So the first 3 presentations are patients that if they require oxygen, it's going to be supplemental, high or low flow. That's the first 3 categories. The remaining 3, which is 4, 5, and 6 now. 4, 5, and 6 is the category where you will need to breathe for the patient because their ventilation is compromised. So patient number 4 is a patient that is semi-responsive, but their ventilation is compromised. So I'm now starting to think about upper airway adjunct, suctioning, and stuff like that. That's number 4. Semi-responsive, ventilation compromised. Number 5 is a patient that is unresponsive with a pulse, with poor chest rise or no chest rise. So number 5, I should say, number 5 is a patient that is unresponsive with a pulse, with poor chest rise or no chest rise. Again, with this patient, I should be thinking about the use of an airway adjunct and ventilation management. And with the final category, which is number 6, is a patient that is unresponsive and no pulse is present. So this is your patient in cardiac arrest. So a patient can present in 6 categories. And again, as an EMT that is working in the field, it is your responsibility to ensure that if you have a patient that falls in one of the 6 categories, you can apply your patient assessment appropriately. That is your goal. If you're able to do that, then you can manage any patient. Now, the first thing that we need to consider, the first thing that we need to do in the primary assessment is we need to form a general impression of the patient and the environment. Form to determine the priority of care. The first part of the primary assessment, this is the very first part. Make a note of the person's age. Does not have to be the exact age of the patient. I would say more consider the age group or developmental age. Is it an adult? Is it a pediatric patient? Is it a geriatric? Consider the sex and the race, the patient's level of distress, and their overall appearance. Note the patient's position. Avoid standing over the patient. Address the patient by name. Introduce yourself. Ask about the chief complaint. Address live threats immediately if they are present. Another area that is very weak for EMTs in Jamaica is communication. So there seems to be some challenges in terms of how you all are communicating with patients and gathering information. The interaction is not strong, especially for medical patients. You're not asking the right questions. You don't know how to deliver the questions. So determine if your patient's condition is stable but potentially unstable, or the patient is unstable. So is the patient ABCs okay? Or is the patient stable now, but whatever the injury is or the illness is, they have the potential to become unstable? Or is the patient just unstable at this time? Scan for signs of uncontrolled bleeding, and if present and it is significant, it needs to be addressed. So uncontrolled external bleeding take priority over the other assessments. Now, once we have formed a general impression, we need to now interact. We need to interact with the patient and ascertain the patient's level of consciousness, or LOC. So the level of consciousness can tell you a great deal about the patient's neurologic and physiologic status. Assessment of an unconscious patient focuses on airway, breathing, and circulation. Sustained unconsciousness should warn you of a critical respiratory, circulatory, and central nervous system problem. Your goal is to assess 1 brain, 2 lungs, 1 heart once you have a patient that you would consider to be critical. If you're able to hear me clearly, raise your hand. All right, that's good enough. So that's not an issue on my end, Mrs. Mackay. That's a connection issue on his end. Lower your hands, please. All right. Lower your hands, please. I will not take any questions at this time. Thank you. All right, let us continue. Still on the level of consciousness. So consciousness, the patient can be conscious with an altered level of consciousness, and it may be due to inadequate perfusion. It could also be caused by medication, drugs, alcohol, or poisoning. And basically what they're saying is the patient can be conscious with disorientation. So they are conscious and they are alert, but they are not fully oriented. We will use the AVPU mnemonic. So to assess for responsiveness, use the AVPU mnemonic. A is awake and alert. And if we're checking to see if a patient is awake and alert, we need to also consider their level of orientation, which tells us their mental status. The patient can be responsive to verbal stimuli, the patient can be responsive to pain, and the patient can be unresponsive. And the methods that we currently use, you can pinch the patient's earlobe, you can put pressure on the supraorbital nerve, you can pinch the neck, and this is to get a reaction to a painful stimuli. You can also put pressure on the cuticle of the nail using a pen. As I stated previously, if you're going to consider whether your patient is awake and alert, you need to also consider the patient's level of orientation. And for a patient to be fully oriented, the patient must be able to tell you who they are. The patient must be able to tell you where they are. The patient should be able to tell you what time of day it is and even which day it is. And they should be able to tell you clearly what has happened. And we assess orientation in that order. So person, place, time, event. Long-term, intermediate, short-term memory. If there is an issue with one of these areas, so if there's an issue with person, place, time, or event, then the patient is said to have an altered mental status. Or if the patient is behaving in a manner that is not considered the norm for that patient, then they have an altered mental status. So the person, place, time, and event evaluates long-term memory, intermediate-term memory, and short-term memory. Altered mental status is any deviation from alert and oriented to person, place, time, and event, or any deviation from the patient's normal baseline. Identify and treat life threats. Very important in your primary assessment. The goal is not to obtain bits and pieces of a history. It is to address things that can kill the patient, and you cannot manage something that you have not properly assessed. If your primary assessment is not done properly, you will have multiple gaps in your assessment. If you have multiple gaps in your assessment, then your treatment is going to be poor, and all you're really doing for that patient is pick up and run. Conditions that cause sudden death: airway obstruction, respiratory failure, respiratory arrest, shock, severe bleeding, primary cardiac arrest. In most cases, begin with airway followed by breathing and circulation. However, depending on the patient's presentation, if excessive bleeding is present, your approach might change to CAB. If the patient is in cardiac arrest, your approach might change to CAB. Once we have ascertained the patient's level of consciousness, we will now focus on the upper airway. Moving through the primary assessment, stay alert for signs of airway obstruction. Ensure the airway remains open, patent, and adequate. So you assess the patient's airway. If it's not open, we position, we look, listen, and feel, and we simultaneously feel for that pulse. Once a patient is not talking to you, position the airway, ensure it's clear, look, listen, feel, simultaneously feel for that pulse. If there is no chest rise present, then you will assess the pulse. If chest rise is present, you assess the chest rise first. Now, responsive patients. Patients who are talking or crying have an open airway. Watch and listen to how patients speak. If you identify an airway problem, stop the assessment and work to clear the patient's airway. So if you think the patient has an airway issue, fix the problem. For unresponsive patients or patients that are not talking to you, because the patient doesn't necessarily have to be unresponsive. The patient can be semi-responsive or only responding to pain. If the patient is not communicating, position the airway using the appropriate method, ensure it is clear, look, listen, feel, simultaneously check for a pulse. If there is no chest rise present, evaluate the rate, rhythm, and strength of that pulse. If chest rise is present, then you need to assess that first. And when we're assessing chest rise, we look at rate, rhythm, quality, and depth. So for unresponsive patients, immediately assess the airway, use the jaw thrust technique when necessary, use the head tilt chin lift technique when necessary. And I expect you to know when these techniques should be applied. Relaxation of the tongue muscle is a cause of airway obstruction, which is very common in unresponsive patients. Signs of airway obstruction in an unconscious patient: obvious trauma, blood or obstruction, noisy breathing, which can be snoring as a result of the tongue, bubbling or gurgling because of fluid, crowing because of constriction, or abnormal sounds. The patient can also be breathing extremely shallow, or there's absent breathing. A patient is breathing extremely shallow, you need to determine if the patient's LOC is affected by that shallow breathing. If the LOC is affected by the shallow breathing, your patient is in respiratory failure. If there is an absence of breathing, your patient is in respiratory arrest. Now, once we have evaluated the upper airway, then the next phase of our assessment is to evaluate the lower airway. And when we evaluate the lower airway, we have to think about ventilation, oxygenation, and respiration. That's why your assessment must be geared towards. So make sure the patient's airway is open, make sure the patient is make sure the patient's breathing is present and adequate. So ask yourself, is the patient breathing? Is the patient breathing adequately? Is the patient hypoxic? So you need to consider the patient's level of consciousness. Then you're going to look at the rate, how fast or slow the patient is breathing per minute. You're going to look at the rhythm. Is it consistent? Is there a regular pattern of chest rise or is it irregular? So rate, rhythm. You're going to look at the quality. Is there muscle use present? Is there abnormal sounds present? Is it positional? What is the patient's pulse ox on room air, especially if it's a medical patient? Is there adequate chest rise? That's depth. Is there visible chest rise? So we look at rate, rhythm, quality, and depth. Based on those assessments, we can determine if the patient is having a ventilation issue, oxygenation problem, or a respiration problem. And then we manage it appropriately. A lot of the EMTs cannot do a proper breathing assessment. That's what the previous research is showing, and that's what some of the data is showing. The primary assessment for breathing is very weak. Now, consider providing positive pressure ventilation with an airway adjunct when respirations exceed 28 breaths per minute and respirations are fewer than 8 breaths per minute. Now, anytime you are going to make a decision to breathe for a patient, it should never be based solely on numbers. So if I am going to bag a patient, I cannot use numbers alone to determine if a patient needs to be bagged. I must consider the patient's level of consciousness. I must consider the patient's rate of breathing. I must consider the consistency of that breathing. I must consider whether muscle use is present, whether it's positional, whether abnormal sounds are present. What is the pulse ox on room air? Can I see adequate chest rise bilaterally? Based on those considerations with the breathing number, the rate of breathing, I will be able to determine if the patient requires positive pressure ventilation or assisted or artificial ventilation. So never make a decision to bag any patient based on their rate of breathing alone. And the same goes for supplemental O2. Never ever make a decision to give a patient oxygen only based on the rate of their breathing. That is madness. There's no way you can determine if the treatment that you're giving is for ventilation, oxygen, or respiration by rate. It's just not possible, right? So supplemental oxygen by a high or low flow device cannot fix a ventilation problem. Supplemental oxygen with a patient with fluid in their lungs cannot fix the problem. So if your assessment is not thorough, you can't pick that up. So if you didn't listen to a patient lungs that has a history of heart failure and is having fluid backed up in the lungs, you're not going to know that fluid is in the lungs. You didn't listen to the patient lungs with a collapsed lungs, you're not going to know that the lungs is collapsed. So your assessment needs to be thorough. Reduce the amount of gaps in your assessment and your management will be more efficient. Now, the goal for oxygenation for most patients in an oxygen is an oxygen saturation of approximately 94 to 99%. However, bear in mind that a patient with chronic chronic lung issues or chronic lung problems will never have a normal pulse ox. It doesn't matter how much oxygen you give them. A patient will not have a pulse ox that's normal. And for some patients, based on their presentation, especially your MI and possible stroke patients, if they don't need oxygen, don't give it to them. Oxygen can cause more harm than good for these patients. Observe how much effort is required for the patient to breathe. So do you see retractions? Is there use of accessory muscles? Is nasal flaring present? Is a patient communicating in 2 to 3 word dyspnea or staccato speech? Is the patient in the tripod position, sniffing position? Is the breathing labored? Are they working hard to breathe? Now, when you complete your breathing assessment, your patient will fall into respiratory distress. You'll either put the patient in the category of respiratory distress, respiratory failure, or respiratory arrest. And for some reason, as I said, EMTs struggle with this concept. And I don't fully understand why, because it's very simple. A patient that is in respiratory distress, distress, the word distress, respiratory distress is defined by adequate chest rise. That's it, full stop. So if a patient is in respiratory distress, whether it's mild, moderate, or severe, they have visible chest rise. Visible chest rise defines distress. Once the visible chest rise becomes compromised, so if it's poor chest rise or no chest rise, then you have a patient that is moving into failure and arrest. So respiratory distress is defined by chest rise. That defines it. So with respiratory distress, there will be an increased work of breathing, there's an increased effort, and the rate goes up, and the patient can still communicate if it's mild or moderate. When it starts to become severe, their level of consciousness starts to change. Now, also keep in mind that rarely, if ever, you will be required to bag a patient that is breathing very fast, right? Rarely that will occur. Generally, we tend to have to bag patients that are breathing very slow or not breathing any at all. And it's also extremely difficult to bag a patient that is breathing very fast. Also keep that in mind. So again, respiratory distress is defined by chest rise. So if your patient is having a breathing problem and there's visible chest rise present, your patient is either in mild, moderate, or severe respiratory distress. If you catch the patient close to severe respiratory distress, even if you're providing supplemental treatment, you need to be prepared to breathe for that patient because they are close to failing. And one of the key signs of severe respiratory distress is the patient's level of consciousness starts to decline. They still have visible chest rise, but the level of consciousness starts to decline. The breathing becomes more labored. Breathing rate might still be up, or you start to catch it at normal range. That means it's coming down. Now, if respiratory distress is not addressed, it will lead to respiratory failure. And respiratory failure is defined by a change in the patient's level of consciousness and poor chest rise. So poor chest rise and a change in the patient's level of consciousness defines respiratory failure. So respiratory failure occurs when the body is inadequately oxygenated or ventilation is inadequate to meeting the oxygen demands of the body. The ultimate result of respiratory failure, the ultimate result is respiratory failure if it is not corrected. So if respiratory distress is not addressed, the patient is going to become deoxygenated, and it can lead to a ventilation issue, and then the patient now trickles into respiratory failure. And if respiratory failure is not addressed, the patient will stop breathing. That's respiratory arrest. Now, after we have assessed breathing, which is rate, rhythm, quality, and depth, and determine if we need to treat ventilation issues, oxygenation, or respiration issues, then the next phase of your assessment is circulation. So again, we consider the patient's mental status. We will check the pulse. If the patient is talking to you, you're checking the peripheral pulse. The patient not talking, you check the pulse that is closest to the brain. We will look at the skin condition. So we're looking at the color. We considering the temperature of the skin. We looking for signs of dehydration. In our pediatric population, we're looking at the capillary fill. So these are the things that we consider in the circulation. And of course, we can either firstly check for bleeding, or we can check for bleeding after. It depends on the patient presentation. So bleeding is a part of circulation as well. So assess the pulse. The pulse is a pressure wave that occurs as each heartbeat causes a surge in the blood circulating through the arteries. Palpate, feel the pulse. If you cannot palpate a pulse in an unresponsive patient, begin CPR. However, note that for your pediatric populations, specifically your neonates and your infants, they don't need to be pulseless for you to start CPR. Pulse just need to be below 60. We will look at the skin condition. So evaluate the patient's skin color. We look at the palms for changes. So we look peripherally. If changes are present peripherally, look for it centrally. Look at the color of the lips. You can check the mucous membranes under the eyelids. And you consider temperature. If you are considering an accurate temperature reading based on the current COVID guidelines, that should be done prior to making contact. So if you suspect COVID, then temperature check should be done before making contact with the patient. In the circulation assessment, we're not really focused on an exact temperature reading. What we're really trying to identify with the skin temperature is if signs of shock are present. Is this patient warm and dry? Is the patient cool and clammy? Is the skin excessively hot? So we're really trying to determine if the patient is showing signs of shock. Check for moisture. So does the patient show signs of hydration, proper hydration, or is the patient dehydrated, or is the patient overhydrated? And you check your capillary refill time, or CRT, which is a more appropriate assessment for the pediatric population. A normally functioning circulatory system perfuses the skin with oxygenated blood. That's the main purpose. Perfusion. Now with skin color determined by the blood circulating through vessels and the amount and type of pigment present in the skin. Poor circulation will cause the skin to appear pale, white, ashen, or gray. When there is an issue with blood flow, blood vessels constrict and redirect blood flow to the core areas of the body, and that causes the skin to get very pale. If that lingers, then it will lead to an oxygenation problem where the skin will start to become blue or grayish, dark gray in color. and that is what we call cyanosis. Hold on, let me back up a bit. Okay. Right now, skin color, continuing with skin color. When blood is not properly saturated with oxygen, it appears blue. There will be pale skin before blue skin. Blue skin is bad. So cyanosis, if present, is not good, especially if it's present centrally. Changes in skin color may result from chronic illnesses. So if they have kidney issues, they have problem with the liver, it can cause the skin to have a yellowish color. Skin temperature. Normal skin will be warm to the touch. Abnormal skin temperatures are hot, cool, cold, and clammy. Skin moisture. Dry skin is normal. Skin that is wet, moist, or excessively dry and hot suggests there is a problem present. Capillary refill. Evaluated to assess the ability of the circulatory system to restore blood to the capillary system. Press on the patient's fingernail, remove the pressure. It should take less than 2 seconds for blood to return in the capillaries. The nail bed should restore to its normal pink color within less than 2 seconds. If it is outside of that, then it is said to be delayed. And it can indicate that shock is present. Now, in circulation, we will assess and control external bleeding in our trauma patient. Should occur before addressing airway or breathing concerns if the bleeding is significant. Bleeding from a large vein is characterized by a steady flow of blood. Bleeding from an artery is characterized by a spurting flow of blood. Controlling external bleeding can be simple. Apply direct pressure using your gauze, and you roll a bandage. And if that doesn't work, if your protocol allows and you have been properly trained and you think it is indicated, apply a tourniquet. If direct pressure is not quickly successful, or if obvious arterial hemorrhage of an extremity is occurring, then you may have to apply a tourniquet, but must be within your protocols, must be properly trained to do it. Now, after we have completed our circulation assessment, which we're looking at the pulse, we're considering the rate of the pulse, we're considering the regularity of the pulse, and we're considering the strength of the pulse. We're looking at the skin color, temperature, hydration, cap refill, and we're controlling blood loss using appropriate measures. After we have done all that, once we have completed our assessment of one brain, 2 lungs, 1 heart, there are some questions we should be able to answer. So once we have completed our ABCs, at this time, you should know what your patient's GCS is. So you should know your patient's GCS. You should know if you have a patient that is a load and go or stay and play patient. And you should know if you need to do a rapid scan or a focus on the patient. So these questions should be answered if you have done a proper ABC assessment. What is your patient's GCS? You should know at this point. Is it a load and go patient or stay and play? You should know at this point. Does this patient require a rapid scan or a focus? You should know at this point. Now, rapid scan or a rapid exam identify injuries that must be managed or protected before the patient is transported. That's the goal of the rapid exam. And it utilizes your DCAP BTLS, which you also use in your secondary assessment. It should take 60 to 90 seconds to perform. It is not a systematic or focused physical examination. You're rapidly checking the patient from head to toe. Now, the rapid exam is indicated for your trauma patient based on the mechanism of injury. Once a mechanism of injury is deemed to be diffuse, meaning the potential for multiple injuries exists, then a rapid scan is required for a trauma patient. If it is a medical patient, if the medical patient is not able to tell you sensibly what has occurred, or family members and bystanders not giving you valuable information, then a rapid scan would be required for your medical patient. And with medical patient, we're not only focusing on trauma issues, we're focusing on medical stuff as well. If the mechanism is localized for trauma patients, then you focus on the area that the injury is localized to. If the medical patient can tell you what is happening to the patient sensibly, then you focus on the system involved, or you focus on the chief complaint. Your assessment will be geared towards the chief complaint. So we will determine the priority of patient care and transport. Primary assessment assists in determining transport priority. High priority patients include those with any of the following conditions: unresponsive, difficulty breathing, uncontrolled bleeding. High priority patients, continued altered level of consciousness, severe chest pain, pale skin or other signs of poor perfusion, complicated childbirth, severe pain in any area of the body. The golden hour or golden period. This is the time from injury to definitive care. The treatment of shock and traumatic injuries must occur within this period. So ideally, we want that to occur within 1 hour. So within 1 hour, EMS needs to be notified, EMS needs to be dispatched, EMS need to assess and stabilize the patient as best as possible, package a patient for transport the patient to the most appropriate facility for definitive care. The goal is for this to occur within an hour or in as little time as possible, because there can be factors that pushes the golden hour outside of the 1 hour window, hence golden period. Immediate transport is one of the keys to survival of patients who need immediate care that the EMT cannot provide. Notice that statement said, immediate care that the EMT cannot provide. So if it is something that you can provide, it needs to be done for the patient. So if you recognize that your patient need a airway adjunct and positive pressure ventilation, it needs to be done. It needs to be done. You don't neglect that and put the patient in the back of the ambulance and drive like crazy, go to the hospital, and then the doctors have to do simple basic stuff that you neglected to do for the patient. Patient outcome suffers at the end of the day. And there's a lot of data to support that. Now, within the golden period, there is the platinum 10 minutes. And this is the phase of initial assessment, intervention, and packaging for the EMTs. And if it's a trauma patient, you actually want to complete assessment of the primary You actually want to complete the primary assessment within 6 minutes for a trauma patient. That should be a goal. And when you're being tested, if you cannot complete a primary assessment within 6 minutes, you will not be allowed to pass your practical. So that is important to keep in mind. Now, transport decision should be made at this point based on, excuse me, patient's condition, availability of advanced care, distance of transport, local protocols. That will guide your transport decisions. All right, now let me pause for a bit.